Hey everybody, welcome to our webinar, our ACLS or ECG interpretation for upcoming ACLS students. I want to welcome everybody here. All right. I just want to make sure before we get going into too many other things right now that you can all hear me. So if you can actually type into the comments, say hi, let me know where you're actually logging in from. That'd be fantastic. And all right, let me know that you can hear me. And I'm checking the comments now. And yeah, no, we're seeing people saying hi. This is fantastic. All right, welcome. All right, great to see everybody here. So we can actually get started now that I know everybody out there can actually hear me. So today is all about the education. So I want to let you know that we will not be trying to sell you anything at the end of this webinar whatsoever. Today is just all 100% about the education. But I hope I have your permission to send you a very special email later this week. I don't want to ruin the surprise right now, but this is a super secret email that will only be sent to those who attended this free webinar. So if you weren't on this webinar, even if you registered for it but didn't show up, only the people who showed up for this webinar are actually going to receive that email. I'm very much looking forward to actually sending that to you. But it is a surprise, so I don't want to spoil that for you right now. Right. It is an ECG review for the Advanced Cardiovascular Life Support Program. I'm just going to turn on the camera now so you can actually see me, and I can say hello, how's it going? Great to see everybody, and whatnot. I'm sitting here. I've got my iPad that I'm actually using to present this webinar right now. But for those who don't know me, my name is Chris, and I am the author of my brand new book called ECG Secrets. The Arrhythmia edition, we're actually going to be doing an ECG Secrets 12-lead edition as well. But right now, we're just in the process of releasing the ECG Secrets Arrhythmia edition. It's going to be coming out this fall, and we're going to make sure that we'll make sure everybody out there actually knows about this new book coming out. We are not here today to talk about my new book. We are here to talk about ECGs. But before we even get into that, I want you to know that I know how you feel going into an ACLS course, especially when you don't use ECGs all the time. So we are here to help reduce some of that anxiety, reduce some of that stress. And that's not just for students who take a Resuscitation Canada ACLS program. This is for anybody who's going to be taking an ACLS program basically anywhere, right? So basically this video or this webinar is for people who would like to brush up on their ECG recognition prior to attending an ACLS provider or ACLS renewal program. So if that's what you're here for, fantastic. If you are already an expert in ECGs, then this webinar is not for you. I'm going to be honest with you. You can stick around. We'd love to have you, but we're not going to be really getting into any new information on this webinar. This is just a review to help get people more comfortable with their ECGs prior to going out to their next ACLS program. What this video is not, it is not a comprehensive ECG course. If that's what you're looking for, then I'm going to get you guys to reach out to our office. We'll have the number up at the end, or you can head over to our website at Resuscitation Canada, and we can definitely help you out with a comprehensive ECG program. But this webinar is just a review. We're going to spend, I'm thinking, 45 minutes, an hour, maybe at the most an hour and a half, depending on how many questions we have at the end of the webinar. But literally, this is just a review. It's to help get you more comfortable with ECGs, especially the ones that you're going to see on an ACLS course that you maybe have coming up here very shortly. So this is not a full ECG program. As well, this ECG review is specific to the Heart and Stroke Foundation's official ACLS provider and official ACLS renewal program. These are programs that are taught to the standards of the Heart and Stroke Foundations, and all the ECGs we're going to talk about are directly out of that program. If somebody's teaching a program and they're going well above the standards, or they're going well or kind of taking left turns in the program and getting into some funky rhythms, that's not something we're going to be covering on this video. So this video is covering the standard rhythms that you're going to see on the official Heart and Stroke Foundation ACLS provider program. So now what I got to do is let you know what we're going to cover today. We're going to start by putting each of the rhythms we're going to review into the appropriate algorithm category. So we're going to start off with the bradycardia rhythms. So we're going to see the rhythms that show up in the bradycardia section of the ACLS program. We're going to see the tachycardia rhythms, right? So all the ones that show up in that part of an ACLS program, then the cardiac arrest rhythms, and then the post-cardiac arrest rhythms. Some of the rhythms will actually repeat, and if they repeat, I'll actually reference you back to the rhythm that we talked about earlier, but we put it in those categories so that you would be prepared to see it at that point in the course as well. One example of that is, in the cardiac arrest, we talk about a ventricular tachycardia, but we also talk about ventricular tachycardia in the tachycardia with a pulse algorithm. So making sure that you understand you're going to see it in both of those sections when you go to take the program. So are you ready to get started? I'm hoping you are, because I'm really excited to be able to bring this out to you guys today. I think I should mention that we're not going to be posting a recording of this up quite yet. This is the first time I'm doing this webinar. I've practiced it a couple of times. I think I've got all the kinks worked out, but my hope and my goal is sometime later this week, after I finish this webinar, I'm going to be able to do this webinar again with another group. So we're not going to be posting the recordings just yet, but once we get this webinar and all the associated questions that usually comes up taken care of, then we'll post those videos for people to see after the program. So it's not going to be posted quite yet. But we will be redoing this webinar a couple times before we actually get a chance to repost those. So I'm going to shut the camera off now, because we're going to need more of the screen space to see the actual rhythms that we're going to be using today. So I'm going to shut my camera off so you can't see me. There I go. And no, actually that didn't work. What I need to do is this and send it over there. And now the camera is off. Fantastic, right? I feel a little less self-conscious now that the camera's off, but anyways, we're going to get started here into our first section, and we are here now at the bradycardia rhythms. So one of the things I want you to do while we're going through these is any questions you have, please put them into the chat box as we go. So if a question comes up about a rhythm, put them into a chat box. What I'm going to do is I'm going to try to get to as many of those questions as I can at the end of this webinar. So at the end of this presentation, I'll start answering questions. And anybody whose question I don't get an answer or get a chance to answer, or if the question comes in after we shut down, then what I will do is I will start sending out, as part of that special email, I'll actually include a link to the common questions that actually came up and answers that we have for those questions. So we may even, depending on the question, if we need to do another quick video and add it to that, we will. My goal here is to answer all of your questions with regards to ECGs specific to the ACLS program. If the question is about an ECG that's not technically in the ACLS program, we will try to get you an answer, but we're going to focus most of our time and most of the question stuff at the end of this webinar on ECGs directly related to, again, that ACLS program. So we're here at the bradycardia rhythms section, and we're going to start with our first rhythm. And our first rhythm that we're going to be looking at, correction, we're going to start with the algorithm. This is what happens when you do things live and you're trying to keep everything go smoothly. You make a little faux pas every once in a while. So what I've done first is I have thrown the algorithm up here on the screen. And for somebody, or a patient that is going to be included in this algorithm, right, we have to start with the criteria. So the criteria to get into the bradycardia algorithm is they have to have a heart rate less than 50. So if you can see that right there, we're looking at 50 beats per minute. So the rhythms that we're going to be looking at here are going to generally be less than 50 perfusing beats per minute if they're going to be included in a ACLS program in this section. Right? The next step in the bradycardia algorithm is we need to identify and treat the underlying causes. So one of the most common underlying causes is the oxygenation. So these patients, if they're bradycardic, we should be looking at their oxygen status and making sure that we improve that. But if we can identify and treat any of the underlying causes, please go ahead and do so. If we can't identify any underlying causes, we're going to move on. And the next step in the bradycardia algorithm is we're going to see if they're stable versus unstable, right? So there's 5 criteria listed there in that red box. The first one is, are they hypotensive? So if they have a heart rate less than 90 systolic, that's the criteria we use in ACLS, then we can classify them as hypotensive. Are they showing signs of acutely altered mental status? If they are, then we're going to move on and we're going to treat. Do you see signs of shock? Are they pale, cool, diaphoretic? Again, if it's a yes, just move on and we start to treat them, using the treatments below, Are they complaining of any type of ischemic chest discomfort? Again, if yes, we move on. And then acute heart failure, Wet lung sound showing signs of acute heart failure. If it's a yes, we actually treat them. If they answer no to basically all 5 of those questions, we're moving into that monitor and observe space. They don't need aggressive or immediate interventions. We need to monitor and observe them. And if their status changes, then we would reevaluate them and see if they move into the treatment category. But on most ACLS programs, the most common path you're going to take through this algorithm is your patient will be unstable in some way, shape, or form, and we're going to move into our first treatment. The first treatment being atropine, 0.5 milligrams, fast IV push, and then if that doesn't work, we'll have transcutaneous pacing or dopamine or epinephrine. You can pick any one of those 3 as the situation kind of dictates or as your situation will dictate. So that's just a quick walkthrough on the algorithm. Now let's see the rhythms that you're potentially going to see when you're working in this algorithm. So the first one is a sinus bradycardia. This is a very straightforward algorithm. Most of you, I'm hoping, will be familiar with the normal sinus rhythm. If not, now's probably a good time to reach out to us about a comprehensive ECG program. But a sinus bradycardia, the only difference between a sinus bradycardia and a normal sinus rhythm is the rate. Everything else will be exactly the same. So this is actually fairly close to a 6-second strip. So our rate for this patient would be about 30 beats per minute. The rhythm here, we want to make sure that we're looking at a regular rhythm to make sure that it is a sinus bradycardia. And I can tell you this rhythm, the R to R intervals from here to here to here all look fairly consistent. I could sit there and map it out, but just visually looking, we do have a regular R to R. And the P's, again, they're looking like they're coming at very consistent intervals as well. So we have a nice regular P to P interval to go along with it. When we look at our P waves, are they looking good? So a good P wave basically looks like these ones. Are they upright, pointing upwards? Do they have a nice rounded shape to them? And do they all look alike? And all of these P waves have that upright shape. They all do look alike, and they're looking very, very healthy. So we have some good P waves, and having good P waves tells us that that impulse is coming from the SA node. So the impulse is leaving the SA node, traveling through the atria, ending up at the AV node, right? And then we get that little pause right after the P wave, right? And right, that pause is also important to our analysis as well, but we want to make sure our P waves are good. In this case, they are. Because the next thing we're going to do is we're going to check our PR interval. And what we're going to do is measure from the start of our P wave to the start of our QRS complex. And we're hoping to see it between 3 boxes long and 5 boxes long. Or that's 0.12 seconds to 0.2 seconds. So 3 to 5 boxes. In this case, I'm seeing 4 boxes, right, for our PR interval. Our PR interval will be 0.16 seconds. There, and that's right within normal limits. And the last thing we're going to check is our QRS complex. We want to make sure that our QRS complex is narrow, less than 3 boxes, less than 2.5 boxes, 3 boxes. In this case, it is about 2 boxes when I'm looking at that there. So we've confirmed that we do have a sinus rhythm, and because the rate is 30, it's not right 60 to 100. We call this a sinus bradycardia. Right? You will see this on your ACLS program, right? But there are other bradycardic rhythms that you might see on your ACLS program as well. And the next one I want to talk about is a second-degree heart block type 1, or a Mobitz type 1, right, heart block. And these are fairly common on our ACLS programs as well. You'll actually see this rhythm on the written exam. So just giving you a heads up that this rhythm actually shows up on the written exam. So you might want to pay kind of special attention to it and make sure you actually understand that so that you get the point for this question on the exam. But a second-degree type 1 heart block, right, looks like this. And I'm going to go through how, right, we actually analyze this and how we identify it. So we still need to check and make sure, right, find out what the rate is. Again, this one looks to have a ventricular rate of about 60 beats per minute, right, on average, right? 300, 150, 175, 60 to 75 beats per minute coming out of the ventricles. But the atrial rate is actually faster. Right? So I'm going to count the P waves here. We have 1, 2, 3, 4, 5, 6. Right? Our atrial rate is about 80 beats per minute. Right? So the atria is beating slightly faster than the ventricles, right? And when we see that variation, what we need to do is make sure we're mapping out what's called the R to R intervals and, right, the P to P interval. So whenever our atrial rate is different than our ventricle rate, we have to take one more step, and that step is to map out the R to R, right, intervals. So I'm looking at between this R wave here and this R wave here. Right, and it is 1, 2, 3, kind of 4.5 big boxes. Right, I'm then going to map out the next one. 1, 2. The next one is like 4 big boxes. This is like 4.5. This is 4. And if you're doing this on a real ECG strip, right on the ECG strip, just like I am, this is actually what I do with all my strips. Right? My next R to R interval is huge, right? And it's like 1, 2, 3, 4, 5, 6.5, right? Big boxes, right? You know, right? So about 65 millimeters if you want that in an actual measurement. And I have this P wave right here that is missing a QRS complex, and that might be important as we go through trying to figure out what is going on with this rhythm. So we know that this rhythm is, right, irregular. The ventricles are coming at irregular beats, right? Next thing we want to do is look at the P waves, right? This will tell us where the impulses are coming from. So I'm looking here and I see this P wave right here it looks the same as this P wave, and it looks the same as this P wave, and this looks the same as this P wave, and it looks the same as this P wave. So that basically tells me that, right, those P waves are being generated from the SA node, right? And I'm checking the P to P interval, right? So in this case, we have basically 1, 2, 3, 4 boxes, 1, 2, 3, 4 boxes, 1, 2, and the P to P interval is pretty solid, right? The P's are coming at their regular intervals. So we have the ventricle rate, or the QRS complexes, coming irregularly, but the P waves are coming at a fairly, right, kind of regular, right? And that's kind of important to note as well. So the, right, kind of that P to P interval seems to be, right, normal. Next, I want to measure that PR interval, and I'm going to measure it in a couple of different places to see if there's any variance from one complex to another complex. So I'm going to start with the PR interval right here. I'm actually going to change my pen color so that we can actually change my pen color to blue. So I'm starting here, and I'm checking here, and my PR interval on this, right, complex is about 4 boxes, or 0.16, right, seconds. I'm then checking the PR interval here and the PR interval here. Ooh, and that's a little longer. That's right, 1, 2, 3, 4, 5, 6, 7. Right, 7 boxes, right? All right, so we'll just put 7 boxes in there, save me doing the math in my head. Right? And then I see that this PR interval is even longer. We got almost 9 boxes. Wow. So we went from 4 boxes over here to 7 boxes here to 9 boxes here, and then we dropped a complex, right? It has dropped and it is not there, right? I have a little rhyme for figuring this out, right? So when I'm looking at a second degree heart block type 1, in each kind of set of complexes, a type 1 heart block will drop 1 complex only, right? So if we look at the progression here, it gets normal, longer, longer, drop. Normal, longer, longer, and we have another drop over here. It'll always just drop 1 QRS complex, and then it'll reset and, right, start the whole process over again. So a type 1 drops 1 complex at a time, or a type 1 drops 1. So this is a second degree type 1. I can finish my, right, my analysis, and right, just for the final verification, we also have a narrow QRS complex as well. So I hope that helps you understand what you need to do when you print off one of these strips and you want to figure out if it's a second degree type 1 or a second degree type 2, or if you're looking at this on a test document, right? Do the process, figure out the ventricle rate, figure out the atrial rate, right? Tell me, are the ventricles coming regularly or irregularly? In this case, it's irregular. Are the atria firing regularly or irregularly? In this case, it is regular, right? Do the P waves look good? Are they normal? Are they upright? Right? And then the key to this one is that lengthening PR interval, that space between the start of the P wave and the beginning of the QRS complex, right? If that is lengthening and you are losing a complex after, right, a couple of those complexes lengthen, that is the hallmark sign of a second degree type 1. I also have another way of, right, thinking about, right, second degree type 1s, just to kind of put it in a different context, right? And I think of this as a relationship, right? I've been married to my wonderful wife for over 14 years now. She's wonderful. But, we get along good, right? And I'm just going to take off my marks here, right, for a second and clear all my markings. Fantastic. So you know what? Today we're doing fantastic. We love each other. We're treating each other well. I'm the P-Wave, right? She's the QRS complex. But tomorrow, you know what? I pulled kind of a bonehead maneuver. I forgot to empty the dishwasher. I forgot to do the laundry or whatever I was supposed to do. And she's kind of being a little distant and keeping, right, she's staying away because she doesn't want to start a fight. But on the third day I went and I really screwed up on the third day. She's really upset with me now. She's really keeping her distance. She's actually won't even come out of the bedroom. She's hiding up there. I'm in the basement. Really, really screwed up. Then on the fourth day, she decides, you know what? I'm just going to go out with my friends and I'm not even going to go home and deal with my husband, right? Who's a lazy slob. And, right, her friends convince her that, you know what? I'm really a good guy because I think I am. And, right, so convince her to go back home, right? Give it another try. So she comes home. We give it another try. Everything's working out just wonderful. And then, you know what? I do really good. I actually, empty the dishwasher on this day. But the very next day, I take that all for granted again, and I forget to empty the dishwasher, and she gets frustrated. And then the next day, I really get self-absorbed and really forget. And she has to go back out with her friends, and they have to convince her again to give me another chance. And she does, and she comes back. And that is how I remember a second degree heart block. Mobitz type 1 is this is just kind of the process of being married, as I go through. So I don't know if that analogy helps you. I hope it does, but I don't know if it helps you or not. But if it is, fantastic. Right? What I'm going to do now is we're going to move on to the next type of heart block that you might potentially see on an ECG program, or ACLS program, and that's a second degree heart block type 2. And this one here is a little different. Right? We're going to do the exact same thing, so we're going to figure out the rate. I'm going to look at this one here, and I'm going to go, we have 300, 150, 100, 75. All right, the ventricular rate when I do have complexes is about 60. Let's look at the atrial rate here. So we have, 300, 150, 100, 75. Ooh, the atrial rate's about 62. But I have a, missing complex sitting right here, and I have another missing complex right here. And those are kind of worrying me. So my atrial rate is about 60. My ventricular rate, when I do have complex, is about 60, but in reality, it's probably more like 30, right, actual perfusing ventricular contractions, right? And now I want to check my my R to R's. So I'm checking my R to R's, and from here to here, that's pretty much the same as right here. So we have 3, 4, 5, and then we have another 5, and then we have this whole big mess here. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. We have like 15 boxes between that last one. So we've got some missing complexes. We've kind of confirmed that there. Our P's, we check our P to P interval here, and look at that. Right, it is going pretty regularly, though. That's like 5 boxes and 5 boxes and 5 boxes and 5 boxes. All right, so the P's are coming regularly. The QRS complexes are not coming regularly, and basically, that's going to help us determine what is going on here. Then we're going to check our PR intervals. When we actually have a QRS complex, I want to check our PR interval. So I'm just going to change pen colors again. I'm going to go green here, and I'm checking here. And you know what? That's like 4 boxes. That's pretty good. And I'm checking here, and that's like 4 boxes. So our PR interval is actually normal, right? Or it's stable. It's not lengthening like we saw in a type 1. Type 1, we saw that lengthening and then the complex drop. In a type 2, we won't see that PR interval actually lengthening. What we're actually going to see is the PR interval stays pretty much the same. So we know our PR interval here is like 4, and our PR interval here is 4 as well. So our PR interval stays pretty much the same. And then the last thing we need to check, again, is we need to check for our, sorry, I want to go to a different color here. We're just going to go to blue. And I'm going to check my QRS width, and in this case, it is narrow. We know that that is narrow. So our PR intervals are good, right? We have good P waves. They look normal. They all look the same, right, as well. But our atrial rate is definitely regular, but our ventricular rate is irregular. Hang on a sec, guys. I got somebody who just snuck in here, right? Okay, guys, I'm back. So sorry about that. Just had somebody come in here. I'm actually at a hotel here in London using our training room here at the hotel to deliver the training. So apologize, I am back, and we can get started, or we'll just carry on from here at this point in time. So we were at the second degree heart block, and we have, we have our second degree heart block. The reason it's a second degree heart block is that PRI is not lengthening, right? The PRI is staying the same. The other thing that can happen, it doesn't always happen, but the other thing that can happen with a second degree type 2 heart block is it can drop multiple complexes in a row. So if you actually look here, we've lost 1, we've lost 2. Whereas when I'm looking at a second degree type 1 heart block, it will always only drop 1 complex at a time. It'll never drop more than 1. So a second degree type 1 will only drop 1 complex at a time, but a second degree type 2 can potentially drop more than 1. So to tell the difference, second degree type 2 heart block, right? The PRI, right, or the space between the start of the P wave and the start of the QRS complex is going to stay the same, or is going to be constant in a second degree type 2 heart block. So I'm hoping that also helps you determine what, how to figure out what this heart block is, right? Especially because you will also see this one, right, on some of the written exams as well. So. And you'll also see it in your scenarios. So this will help you. And don't be afraid to write on your strips, right? That's one of the things I tell everybody is, take your pen, write it out, right? Make all these notes to help you get to the end of the process and come up with a diagnosis, right? Or an interpretation, I should say, of your ECG. The next heart block we're going to look at, I hope you'll bear with me for a second. I'm just going to grab a quick drink of water. The next heart block we're going to look at is the third degree heart block. Right? And using my relationship analogy again, a third degree heart block is a divorce between the atria, or the top half of the heart, and the ventricles. They're operating completely independent of each other. So we're going to look at this rhythm here, and we're going to start by figuring out both our atrial rates and our ventricular rate. So, I'm going 300, 150, 100, 75. All right. So this the ventricular rate here on this one is about 50 beats per minute. And I'm going to try to figure out the atrial rate. I'm going to find two P waves here. I'll just change colors on my pen again. So I'm going to use this one here. So we got 300, 150, 100. Call this about 75 or 80. So the atrial rate is 75. The ventricular rate is 50. All right, we do have kind of a discrepancy there when we're actually looking at this rhythm. So what I want to do now is figure out, is this rhythm regular or irregular? So going back to my blue colored pen here, right, I'm going to just count the boxes. 1, 2, 3, 4, 5, 6. All right, we have 6 big boxes between there. 1, 2, 3, 4, 5. Ooh, we got 6 boxes between there. All right, we have 1, 2, 3, 4, 5, 6 boxes in there. Those QRS complexes are coming at a pretty regular, right, kind of rate. So I want to check the atrial rate as well on this rhythm. So, I'm not sure what happened there. Oops, I hit the off button. My bad. All right. This is what you get when you do these things live. All right. So, looking at the atrial rate here, and between here and here we have, call that 3.5 boxes. And I go to the next one, I go 1, 2, 3. I would expect to see a P wave here, but there's this big QRS complex sitting there. All right? And I know that QRS complexes can hide P waves. So I'm going to use that mark there as kind of a reference. And what I'm going to do is I'm going to map that out again and see if another P wave, right, comes out 3.5 boxes later. So we got the half, 1, 2, 3. Oh, look at that. Right, my next mark lands on a P wave. Well, let's map it out one more time. 1, 2, 3.5. And I know again that a P wave can be hiding inside of a QRS and a T wave, because QRS complexes and T waves are much stronger than P waves, so they will mask those. But I'm going to go one more time just to see if my theory pans out here. So we have 1, 2, 3, and a ooh, right? Using this methodology as you go through, I can tell you more than likely that we do have a P wave coming at regular intervals, right? It's coming every 3.5 big boxes there, right? So my atrial rate, 75. I have P waves coming at regular intervals, so my P waves are coming regularly. The ones that I can see, the ones that aren't involved in or hidden in QRS complexes, they all look the same. So they're probably coming from the SA node, right? More than likely, because of just the way they look, right? They do look normal in size. But it's really hard to find a pattern to the PR interval here. If I measure the PR interval on this complex, it's like 4 boxes. And then I measure it on this complex, that's like 15 boxes. And then I measure it here on this complex, and I've got 10 boxes. Wow, it's not like it's getting longer or shorter. It's actually, right, just kind of scattered all over the place. The last part I want to check on this is I want to see, is my QRS complex wide or narrow? So I'm going to just come over here and I'll grab my orange marker and I'm going to measure from here to here. That's about 3.5 boxes, which makes it wide. So I actually have a wide complex sitting there. I have P waves coming at regular intervals, but they're doing their own thing. So I have P waves doing their own thing. I have QRS complexes that are coming at regular intervals, and they're doing their own thing. And one of the hallmark, ways of figuring out a third degree heart block is the ventricles are doing their own thing, and they're doing it at a regular rate. And the atria are doing their own thing, and they're doing it at a regular rate, and they're not talking to each other. Using my relationship analogy, this is the divorce, right? The atria has gone and actually divorced the ventricles, and here's what you're seeing. This is a result of that divorce. I actually have right over here on, just gonna hit play, there we go. My diagram of the heart here. What's actually happening in the heart in a third degree heart block is, the SA node is firing, and it's firing, and it keeps firing, and we're getting nice P waves, and nice P waves, and nice P waves, and nice P waves. There is this cutoff somewhere in there. Remember, this is not to scale, so I hope you'll forgive me if it's not exactly accurate. And then the QRSs are actually being developed in the ventricles, or it could be much higher up, but in this case, it's in the ventricles. And those QRS complexes are coming at regular intervals. But they're all happening, right? And I guess, right, I should make that a little wider. Let's just do this, right, a little differently. It's all happening independent of each other, as opposed to being coordinated. So we basically have two separate electrical systems here doing their own thing. If I were able to shut off the ventricles and just look at the atria, I would see this top line right here. If I were able to shut off the atria and just look at the ventricles, I would only see, right, the bottom line down here at the bottom. So I hope that helps to kind of clarify what is actually happening during a third-degree heart block. I'm going to head back to our presentation here. Here we go. Again, if you have any questions as we're going through these, please put them into the comments. I do promise that I will answer them, whether it's by email or we're sending out another video to follow up with this one. But I'm hoping that my commentary here and my drawings are helping you to understand how to actually interpret these ECGs. So those are all of the bradycardia ones, right? We're going to move into the tachycardia ones, and the first thing we'll look at here is the tachycardia with a pulse algorithm. Here, again, there's two pathways that you can go down this algorithm. One of them is they're unstable, right? And it's the same criteria from the bradycardias. It's actually all listed there in the red box. If they're unstable, we treat those with the appropriate synchronized cardioversions. And if they're stable, right, we're going to follow the stable pathway. And then we need to determine if it's a wide or narrow complex, right, tachycardia when we're doing those, right, making those treatment choices as well. So that's going to be our focus here, is identifying the tachycardia and then identifying whether it's wide or identifying whether it's narrow, right, as we go through. So our first rhythm, and again, I've been talking a little bit here. I'm just going to grab a quick drink of water. First rhythm we're going to talk about is the supraventricular tachycardia. And I'm going to calculate, right, I'm going to do it the same way I do all the other rhythms. I'm going to calculate the rate. So starting from here, 300, call this rate like, 290, right? This, right, heart is beating pretty fast, right? I'm checking to see if it's regular, right? And I can tell you, that's looking fairly regular for the most part. I don't really need to do much with that. Can I see P waves here? Technically, I can't, right? And I don't know if there are P waves or not. The definition of a P wave is it will be no longer than 3 boxes wide, right, and 3 boxes tall. So if I expand this right now and I actually measure how big this, right, actual wave is that could potentially be a P wave, it's actually 5 boxes tall and almost 4 or 5 boxes wide. So definitely not a P wave. It doesn't meet the criteria to be a P wave. On this, right, more than likely that's a T wave. There is the potential that the P wave is hiding back there, but right now I can't definitively say that there is a P wave. So one of the things that we're going to need to do, or one of the things we can't do because we can't call that a P wave, is we can't do a PR interval. The last thing I want to check is, right, what is, or how wide is my QRS? In this case, it's just under 2 small boxes. So that makes it less than 0.10 seconds. So this is a narrow, right, QRS. We call this a supraventricular tachycardia because it's coming from above the ventricles. I can't prove it's coming from the SA node because I can't see a P wave. I can't prove it's coming from somewhere in the atria because, again, I can't see those P waves, but I can assume that it's, right, the impulse is originating above the ventricles, and it's an assumption because we have that narrow QRS. So that's how we figure out, right, what an SVT is we look to see, right, if it's a narrow QRS, and if it's going so fast that I can't see the P waves, then, right, I can make that assumption, right? We're going to call this a narrow complex tachycardia, also known as a supraventricular tachycardia. On the other side of the spectrum, we also have, right, the wide complex tachycardia. So again, I'm going to go through this like I would any other rhythm. I'm going to start by figuring out my rate. So we'll start here, right? We got 300, 150. This is going to be about 175. It looks regular to me, right? So we can confirm that. I don't know if there are P waves or not. If there were P waves, they would be hidden in the previous complex. But there'll be other clues as to what's going to help us with this. Because I can't see any P waves here, we cannot have a PR interval. But this is, right, when we measure the QRS complex, this is definitely wide. Right, it is greater than that 2.5 to 3 small boxes that we use. So, right, we call this a wide complex tachycardia. We can add one more descriptor to that because all of these complexes look the same. And when they look the same, we call them monomorphic. So we call this a monomorphic wide complex tachycardia. The next rhythm we're looking at, slightly different, right? This one's the polymorphic wide complex tachycardia. And again, figuring out rate if I use, right, this complex here, this one's coming at about 300-ish beats per minute, right? And that's right, kind of variable, 300, 200, 300. It's looking pretty chaotic, but those complexes are tall enough that I could potentially be feeling perfusing pulses. So this patient could potentially have a pulse with this rhythm. Same with this one, right? Because we're in the tachycardia section, right, we're going to assume that, right, the patient has a pulse with this. So this patient could potentially have a perfusing rhythm with this, right? It could be anywhere from, 150 up to 300 beats, but this one's between 200 and 300 beats. This one's definitely irregular. We don't have any P waves, so we can't have a PR interval. And I can tell you every one of these QRS complexes, if I were to map them out, they would all be wide. Right? So this meets the criteria for a wide complex tachycardia. And because every single one of these looks different, right, we can't call it monomorphic. Monomorphic means they look the same. So we have the other side of that, which is a polymorphic tachycardia. Another rhythm you could potentially see on your ACLS program is this one here. All right, so I'm looking at this rhythm and, right, I'm going to go through the rate and I'm going to actually calculate a couple of different rates here. The first one I'm going to do, because this is an irregular rhythm, right, I need to kind of average out the rate, and the average rate on this one, if I were to look at this section right here, is about 90 beats on the ventricular side. And then I'm just going to have a look at, I'm going to use this part right here. We got 1 P wave, 2 P waves, 3 P waves, 4, 5, 6, right? Call it 7. We have 7 or 8 P waves happening in about a 1 second time frame. So if I take, 60 times 7, that's about 350 atrial beats. So the atrium, right, is beating, or potentially could be beating at about 300, 350, 400 beats, right, per minute. Ventrically, we're seeing about 90 beats per minute right now. And this rhythm looks irregular. It's actually, right, irregularly irregular. I can't really define any pattern. Because there's so many P waves, you can't measure a proper PR interval on this one, so we can't actually do that. But the QRS complex is, right, narrow. When the atrial rate, right, is that fast, essentially the atria is quivering, right? And a quivering portion of the heart, we actually refer to that as fibrillation. And because I know all of these impulses are coming from the atria, we call this an atrial fibrillation. Right? So if I were to look at this on my heart, what's actually happening is I don't have anything actually potentially coming from the SA node. It's really not doing anything. What I have is I have all these what they call irritable focuses going off, and every 8th one or 9th one is actually conducting, and then we get more, and then another one will conduct, and that's actually what's actually causing, or what's actually happening when that rhythm is present in somebody's heart. The last kind of tachycardia rhythm you may potentially see on an ACLS program is the atrial flutter. Right? So again, let's calculate our rate here. Right? We're going to calculate our ventricular rate. We have 300, 150, 100. Our ventricular rate is about 75 beats per minute on the ventricular side. Then I have these beats here, right? And they're not P waves, right? Remembering the definition of a P wave is it needs to fit into a 3x3 box. And this doesn't fit in a 3x3 box. In fact, it fits into more of a 4x5 box. So, when the wave is that big and it's not sitting where the T wave normally would, we actually call those fibrillation waves. Right? So we have an F wave there, we have an F wave there, right? We have an F wave here, we have an F wave here, and they seem to be coming at pretty regular intervals. If I actually take the F wave interval, 1, 2, 3, 4, 5, there could be another one happening right there, and another one kind of happening right there, and another one kind of happening right there, and another one happening right there. So I'm going to make some assumptions here because I can't see them, but knowing how an atrial fibrillation works, what I actually have here is I have 4 F waves to every QRS complex, right? So it's happening 4 to 1, but I'm going to just calculate out the atrial rate here. We have 1, 2, 3, 4. We have 5 complexes in 60 seconds, right? Works out to 5 times 6, right? 300 beats per minute. Did I do that right? I hope I did that right. Or else I'm going to sound really silly in front of all you people. So my atrial rate's about 300. My ventricular rate is 75. Right? It is a regular rhythm. Right? The atrial rate is happening fairly regularly. The ventricular rate is happening very, very regularly. Because we don't have P waves, we can't actually measure the PR interval. And our QRS complexes are narrow. Right? The key to the name of this rhythm is the size of these waves right here. Because they are bigger than those P waves, we call them flutter waves, and we know that they're occurring in the heart or in the atrium of the heart, so we call this an atrial flutter. And essentially, again, what is actually happening in the heart using our diagram of the heart here is not the SA node potentially, but some other focus within the heart is kind of taken over, and this is a really strong focus, and it's firing 1, 2, 3, and on the 4th one it's conducting, and then it's firing 1, 2, 3, 4, or on the 4th one it actually conducts, and that's actually what's happening in the heart as we go. So let's go back to our presentation here. I hope that helps you understand atrial flutter, and that's going to actually be the last of our tachycardia rhythms. The next section we're going to review is the cardiac arrest rhythms, and most of these should be fairly straightforward, but I want to make sure you guys all have a strong understanding of them. One thing to note, I'm not going to go through how the cardiac arrest algorithm actually works, but it is split into two. All right, so you actually draw a line right down the middle, and right, one side is our shockable rhythm, so this is going to be your V fib and your V tax, and on the other side is going to be our PEAs and right asystoles. Okay, so the algorithm is split. So it's basically two algorithms put onto the same page to help you out. And the first rhythm we're going to look at is ventricular fibrillation. This is just chaos, right? And this needs to be an instantly recognizable, right, rhythm. And it will differ from a polymorphic ventricular tachycardia in the waveform height. It's usually no more than right 2 big boxes. In this case, it's about 1.5 boxes. If it's bigger than 2 big boxes, you can consider it a polymorphic VTAC. The kicker is it doesn't matter when they're in cardiac arrest. If there's no pulse, it doesn't matter if it's a polymorphic VTAC or a ventricular fibrillation. We treat it the same way. We do chest compressions, and we are going to do timely defibrillations, right? And again, that's all going to be covered in your ACLS program. The monomorphic Y-complex tachycardia, I actually walked through this rhythm in the tachycardia section, so if you need to review that, why don't you head back to that section. But the only difference in this section of an ACLS course is this will be pulseless. So just be sure that right, you're checking for a pulse in this because it can have a pulse, but when it's pulseless, we're doing CPR and we are doing right timely defibrillations. I also covered the polymorphic Y-complex tachycardia in the tachycardia with a pulse section, and in this case, right, again, it doesn't matter, right, other than you need to check and make sure that there's actually right no pulse when you're doing this, so that we are doing the CPR and the defibrillations. Hopefully this rhythm is recognizable to everybody. This is another one of those sight rhythms that we call it, and it's asystole. And this is just the absence of electrical activity. A lot of people also, when we teach the program, comment that they want to check the leads and make sure that the leads haven't fallen off when they see this. And that's a good practice. I don't want to say that that practice isn't necessary, but on most common new machines, when the leads fall off, you won't have a straight line. I'm just going to change my pen color here so it stands out a little more. What you're actually going to get is a dashed line, and the dashed line will tell you that a lead has fallen off, and a straight line tells you that the machine is actually sensing a connection from one pad to the other. So that's just to kind of give you an idea of the difference between a pad that has fallen off and a machine that is actually properly connected to your patient. The last one I want to cover in this section is the agonal rhythm. Also can be referred to as a systole with P waves, but basically this is a systole, stable rhythm, but the SA node is still trying to fire. So it's firing, but it's not getting past the AV node. It fires, it's not getting past the AV node. They're not going to have a heart rate with this, and treatment, right, for this, as it is for systole, is going to be, right, chest compressions, epinephrine every 3 to 5 minutes, and then working through the H's and T's. I lied, one more rhythm in this section. We got the pulseless electrical activity, and it's really not a rhythm. A PEA is a clinical situation, not a specific dysrhythmia. It's basically any organized rhythm other than ventricular tachycardia that can be present on the monitor and the patient has no pulse. So right, you're feeling for a pulse, you see this on the monitor. If there's no pulse, you're going to do chest compressions and treat it down the PEA pathway. You will see this rhythm on the written exam. I'm just giving you a heads up. Be very, right, read the questions really well, because in the question it will say your patient doesn't have a pulse. And if you read that, you will get that question. You'll have no problems with that question, but you will see, right, just a regular rhythm in there, but there'll be no pulse, and they want you going down that PEA pathway. So that's just a little tip to help with your success. One more section to go, three very easy, very kind of straightforward rhythms to talk about. And right, most patients, when we bring them back into into the post-cardiac arrest phase of your scenarios, we'll start off in one of those 3 rhythms. The algorithms there, again, I'm not going to spend a lot of time going through it here just for time's sake. I know we're getting close to an hour, and I want to have time to answer some of your questions. But all right, it's there. Review it. They're going to go through it really well in the course. It's actually a great video on the use of that algorithm as well. But the rhythms you'll see during your post-cardiac arrest phase of your scenarios will be like the normal sinus rhythm. And we went through, one of the first rhythms we did was the sinus bradycardia. The only difference between the sinus brad and a normal sinus is a normal sinus is between 60 and 100 beats per minute. So if you want to know how to identify a sinus rhythm, go back and watch that bradycardia rhythm again. And again, just substitute the rate. The rate will be between 60 and 100. Kind of the same thing with the sinus tachycardia. Again, the rate is just going to be over 100, generally between 100 and 150. And to call it a sinus tachycardia, I need to see these P waves. If those P waves disappear, we actually change the terminology to that supraventricular tachycardia. And then our last rhythm is that sinus bradycardia. And again, saw that in the bradycardia section, so I'm not going to spend. I'm not going to go through that here again. You can we are going to post when I send you that email. There will be something for you to do to go and actually review this. But you're reviewing your notes from this one on the sinus bradycardia, and you'll be taken care of. We're at again about that hour mark, which is fantastic, right? I'm trying to keep this on time for everybody, but now I want to ask all of you if you have any questions with regards to any of the specific rhythms that we talked here, and if you do have questions, actually, hopefully your questions are in the comment section. I'm going to start going through them now. I'm going to scroll back up here. I'm going to start going through them, and I'm going to try to answer them to the best of my ability. And any of the really technical ones, again, we will get back to you either by email or we'll post a follow-up to this, and we'll send it to everybody who actually attended today. So we'll take questions. While I'm doing that, I will also just ask, can you let me know in the comments, was this helpful? Did you enjoy it? What can we do to make this better for you? Because this is going to be kind of an ongoing process. I'm working myself to try to get better at delivering these webinars for you. So if you can let me know in the comments, I'm going to read every one of those comments today before I head home and put some notes together. But I really hope that you guys got something out of the last hour. I hope it helps you. And again, good luck on your next ACLS program. If you are looking for an ACLS program, right now I promise no selling, but you can head over to our website and we have lots of programs running in various places across Canada. But I'm going to take your questions now and we'll go from there. All right, so I'm going to start going through the questions and we'll start answering them.